Hi all, welcome to RAAONLINE. Today we are going to look at one important monitoring technique that plays a very crucial role in treating critical care patients. That is central venous pressure. What is this central venous pressure? It is the measure of pressure in the vena cava, either superior vena cava or inferior vena cava or the junction of the vena cava with the right atrium, that is used as an estimate of preload and right atrial pressure. One is pressure, that is right atrial pressure. Another is the volume, that is the preload. It is often used for the assessment of hemodynamic status in the intensive care unit. Not only it helps in assessment of hemodynamic status, but also helps in the management of hemodynamic instability. As newer modality and technology are coming into picture, lot of renewed clinical attention are made to CVP. Now you can monitor the central venous oxygen instead of mixed venous oxygen. What is a central line? Here it is a catheter that provides venous access via the central venous system. That means femoral, intrajugular or subclavian vein to access the superior vena cava or inferior vena cava to reflect the right atrial pressure. The bottom line is you put a catheter to reflect the right atrial pressure. What is the definition of central venous pressure? It is nothing but the pressure exerted by blood against the wall of intrathoracic vena cava. It can be also defined as the pressure at the junction of superior vena cava and right atrium. In physiological term, it reflects the driving force for filling the right ventricle. Your right atrial pressure reflects the filling of the right ventricle. It also indicates the relationship of the blood volume to the capacity of the venous system. In short, your CVP can reflect the blood volume coming to the heart, the vessel tone, capacitance vessel tone, intrathoracic PEEP and intraperitoneal pressure can also alter the central venous pressure. Finally, it can reflect the cardiac function. These are all the various purposes of central venous pressure. The main purpose of putting central line is to reflect on the cardiac filling pressure. What you do is, you put a catheter at the SVC RA junction. This catheter will reflect the central venous pressure will reflect the right atrial pressure, provided there is no abnormality at the SVC RA junction. There should not be any superior vena cava stenosis or some other venous anomaly. And this right atrial pressure will reflect the right ventricular end diastolic pressure, provided the valve in between, the tricuspid valve, is normal. There should not be any tricuspid stenosis or regurgitation there. This right ventricular end diastolic pressure will reflect the pulmonary artery diastolic pressure, provided your pulmonary valve is normal, and this pulmonary artery diastolic pressure will reflect the left atrial pressure, provided your pulmonary circulation and pulmonary vascular resistance is normal, and the LA pressure will reflect the left ventricular end diastolic pressure, provided your mitral valve is normal, and this left ventricular end diastolic pressure will reflect the left ventricular end diastolic volume, indirectly the preload, provided the compliance of the left ventricle is normal. So, for the CVP to reflect the left ventricular end diastolic pressure, all the intracardiac chambers should be normal, and for the pressure to reflect the volume, the compliance of the left ventricle should be normal. So, indirectly your CVP reflects a left ventricular end diastolic pressure, which indirectly reflects a left ventricular end diastolic volume. What are the indications to monitor the central venous pressure? First, you want to know the cardiac filling pressure in certain cardiac conditions like your valvular disease or ischemic heart disease. Administration of vasopressor drug when your pressures are low or patient in sepsis or some other reason to have low cardiac output. Cardiac pacing. You put a sheath in the central line through which the pacemaker wire goes in. Rapid delivery of the drug during cardiopulmonary resuscitation. Hemodialysis, you need a central line. Parenteral nutrition, also you require a central line. And in case of aspiration of air emboli. These are all the various indications for central venous pressure monitoring. Now coming to the most important part, how to interrupt the CVP. Here there are two things. One, you interrupt from the number, and another one is you interrupt from the waveform dimensions. So, two things are there. You interrupt from the number and you interrupt from the waveform. Coming to the interruptions from number. Here, you have to do four things. First, you have to zero the transducer. Next is, you have to level and you have to know where to make the measurement and when to make the measurement. These two things is very important. So, you have to zero, level, where to take and when to take the measurement so that one proper number comes into picture. The first point is zeroing. Here, the first thing is for the pressure transducer to read accurately, you should discount the atmospheric pressure. You open to atmosphere and you flush the line and you zero it so that the atmospheric pressure is discounted from the central venous pressure. So, this is done by exposing the transducer to the atmospheric pressure and the calibrating pressure should show on the monitor as 0. That is very important. This is the first 7. And this transducer should be zeroed several times per day to eliminate the baseline drift. Next is leveling. The level of the transducer should be at the level of heart. This is done to avoid the hydrostatic pressure on the CVP. First, zeroing is to discount the atmospheric pressure. Leveling is done to avoid the effect of hydrostatic pressure on CVP. Here, few anatomical landmark is very important. The fourth intercostal space, the mid-axillary line, which is called the phlebistostatic axis. And few other landmarks are very important. The acromion process, the tragus of the ear and the umbilicus. All are in line with the fourth intercostal space where the heart is located. Another important thing is the conversion of millimeter of mercury to centimeter of water. 1 millimeter of mercury is roughly 1.36 centimeter of water. So, roughly 8 millimeter of mercury means 10 centimeter of water. Now, when to measure the CVP? Usually, CVP is measured at end expiration. Why is it so? During spontaneous ventilation, with onset of inspiration, there is a negative intrathoracic pressure which is transmitted both to CVP and pulmonary arterial pressure. Here, you can see with the onset of inspiration, there is a negative intrathoracic pressure. So, CVP is generally measured at end expiration. But with mechanical ventilation, the reverse happens. The onset of inspiration causes a positive pressure with mechanical ventilation. You are giving positive pressure ventilation. Still, you measure CVP at end expiration because end expiration is also going to be positive in case of mechanical ventilation. With spontaneous breathing in early inspiration, where you are going to breathe in with negative intrathoracic pressure, your RA pressure and pleural pressure is going to come down. And at the end expiration, it is going to be maximum negative and the pleural pressure is around -6 to -8. At early expiration, as the air moves out of the lung, your RA pressure and the pleural pressure becomes slightly positive, and at the end you can see the RA pressure coming back to positive and pleural pressure is also increased. So, usually whether it is spontaneous or mechanical ventilation, you measure the central venous pressure at end expiration. That is the bottom line. You measure at end expiration. Now coming to another important point. What does that number indicates? It is the RA pressure. The normal CVP ranges between 5 to 10 centimeter of water or 2 to 6 millimeter of mercury. But what is more important is the value is not important. It is a trend. Whether it is an increasing trend or decreasing trend or a static trend, that is very important. Usually the CVP is low when the volume is low, or the CVP can be high when the volume is a hypervolemia, or the compliance of the right ventricle is altered, like right ventricular infarction, left ventricular failure, or pulmonary hypertension, cardiomyopathy and cardiac tamponade. If your compliance is normal, here you are giving volume but the pressure is not altered much up to a certain degree, and beyond that stretching, when you give volume, the pressure increases rapidly. That is the normal compliance. But if the compliance is low, there is decreased compliance. Here you can see even with little bit volume, your pressure increases drastically. In case of increased compliance, up to certain point, the curve is shifted towards the right, and still if you give volume, the pressure is not altered, and beyond certain point only, even if you give volume, the pressure is increased. So, with compliance, depending upon the compliance, the volume can cause an increase in pressure. If it is good compliance, it is not going to cause much increase in pressure. But if it is low compliance, even giving little bit volume increases the pressure drastically. Now coming to the most important point. Where do you measure this number? What does that mean? There is the CVP-MEAS. That means the CVP which is measured. Normally, the CVP is measured at the right atrium at the end of diastole, which is the measured CVP. Usually, the measured CVP, for all purpose, you take the atrial contraction, the number which comes with the atrial contraction as the measured CVP. But what is monitored on the screen is the average of the CVP over several cardiac and respiratory cycles. That is the actual mean CVP which comes on the monitor. What is CVP-NAD, which is the nadir, which is the maximum CVP which is seen. It can be seen after transient withdrawing of mechanical ventilation, or you can take it as the CVP which is at the maximum value. And CVP calculated is, here you from the measured CVP, you correct for respiratory pressure induced by the intrinsic peak. For example, you added a PEEP of 8 to 9, you detect that value from the CVP and you calculate the CVP. So, you have the measured CVP, which is usually the atrial contraction and the number which comes with atrial contraction. You have the monitor CVP, which is the mean value of all the CVP over several respiratory and cardiac cycle, and you have the maximum CVP, which is CVP nadir, and you have the calculated CVP where you remove the respiratory pressure which is transmitted by the PEEP. Now coming to the A wave and CVP. What you do is, you take the highest point of A wave and the lowest point of A wave. You measure the highest value of A wave, you measure the lowest value of A wave and divide by 2 to get the mean A wave, which is the mean CVP. The A wave starts after the P wave ends and represents the atrial contraction. That is the bottom line. The high point of the A wave is the atrial pressure at maximum contraction. And what is more important is when the atrium contracts, the atrial pressure is going to be higher than the ventricular diastolic pressure, so that the blood from the atrium can go into the ventricle. When the atrium contracts and the tricuspid valve is open, here atrium is contracting and the tricuspid valve is open and ventricle is there. So, by this pressure, when the tricuspid valve is open, because the tricuspid valve is open, this atrial pressure will reflect the right ventricular end diastolic pressure. That is very important. Your atrium is contracting, the tricuspid valve is open and it reflects the right ventricular end diastolic pressure. Remember, when the tricuspid valve is open and the right ventricle is full, the atrium, tricuspid valve and ventricle are in connection. Therefore, this point represents the CVP. Now coming to another important variable, which is the Z point. The Z point coincides with the middle to end of the QRS complex. It happens just before the closure of the tricuspid valve. In the A wave contraction, the tricuspid valve is open. Now, just before the closure of the tricuspid valve. Now also you have to understand that the right ventricular end diastolic pressure will reflect the pressure because the tricuspid valve is still not closed. This Z point will be very useful when A waves are not visible as an atrial fibrillation. Now coming to the second point of the lecture, which is the interpretation of waveform. Here you have 3 positive waves and 2 negative waves. The positive waves are A wave, C wave and V wave, and 2 negative waves, which is the X wave and the Y wave. Now coming to the waveform with relation to the QRS complex and systole and diastole. A is atrial contraction, which correlates with the P wave. After the P wave, there is a slight delay which shows in the CVP as an atrial contraction and it is a diastolic event. Next comes the C wave, which happens with the ventricular contraction, that is after the QRS complex, and this is a systolic event. Next is the venous filling, which again happens in the systole. Here the volume comes into the right atrium. And X descent is when the atrial relaxes but there is ventricular systole. Finally, the Y descent, which again is due to ventricular diastole. So, 2 waves occurs in the diastole, atrial contraction A wave and Y descent occurs in the ventricular diastole. Your C wave, V wave and X descent happens in ventricular systole. Now coming to each waveform. The first wave is the atrial contraction. The first wave, which is the main wave of the CVP. Atrial contracts and you can see the A wave appearing here. That is the first one. Second positive wave is the C wave. Here the ventricle contracts and this contraction of the ventricle is reflected back on the tricuspid valve, which is seen as a positive C wave. That is C wave. That is the second positive wave. Next comes the atrial relaxation. That is the X wave, which again happens in ventricular contraction, but your atria is relaxed. That is X wave. The fourth wave is the venous filling. Here you can see the volume coming to the atria. Although the atria is relaxed, the volume in the atria is increased. That is the V wave. And finally, Y wave is the tricuspid valve opening and the blood from the atria goes into the ventricle, but the ventricle is still relaxed. That is the Y descent. Now coming to individual waves. The first wave is the A wave, which is atrial contraction after P wave on ECG. This is the most prominent wave. It contracts and pushes the blood into the right ventricle, and this is the A wave. It is an end diastolic event, And the prominent A waves, the A wave becomes very prominent when there is resistance to right ventricle filling, which can happen with right ventricular hypertrophy or tricuspid stenosis. And Cannon A wave, large A waves can happen with AV dissociation, where there is no synchrony between the atrium and the ventricle, or the A wave can absent, which happens with atrial fibrillation. Now coming to the second positive wave, which is the isovolumic right ventricular contraction. Here, the right ventricle contracts and the tricuspid valve is reflected back into the atrium, which is reflected as the C wave. Here, there is closure of tricuspid valve and it moves back into RA and reflected as C wave. It occurs in early systole after the QRS complex on ECG. Coming to the next wave, which is a negative wave, which is called X descent. Here, you have two descent, X and X dash. X is atrial relaxation. This is the C wave, this is the A wave. The first is atrial relaxation. The atrium is relaxed, that is X component. And X dash is the downward pull of the tricuspid annulus. Here, there is a downward pull of the tricuspid annulus. So, two X descents are there. This is the C wave, this is the X wave, and this is the X dash. This X is due to atrial relaxation and X dash is due to downward pulling of the tricuspid valve in ventricular contraction. And this is also a mid-systolic event, and with this you can say about the right ventricular performance. A dominant X descent means the right ventricular systolic function is good, but a diminished X descent means a poor RV systolic function. By looking at the X descent, you can say whether your RV systolic function is good or not. Now coming to the P wave, which is nothing but the filling of the atrium from the blood from the SVC. Here you have lot of volume in the atrium. The atrial volume increases and it is reflected at a positive V wave. It is a late systolic event, and here the V wave peaks after the T wave in the ECG. Prominent V wave can be seen whenever there is increased venous return or tricuspid regurgitation or a large left to right shunt like in ASD. Now coming to the last negative wave, which is the Y descent. Here the tricuspid valve is open and the blood from the atrium goes into the ventricle. By opening the tricuspid valve, there is a decrease in atrial pressure. And the tricuspid valve opens and the blood from the atrium goes into the right ventricle. Exaggerated Y descent can be seen in constrictive pericarditis, and attenuation of Y descent can happen with tachycardia, cardiac tamponade and tricuspid stenosis. So, briefly to summarize the various waves seen in CVP, the A wave is due to atrial contraction. Your C wave is isovolumic ventricular contraction, which reflects on the tricuspid valve and present as a positive C wave. The X descent is atrial relaxation and ventricular contraction. V wave is venous filling of the atrium, and Y descent is tricuspid valve opening and the blood from the atrium goes into the ventricle, but the ventricle is still relaxed. Now coming to few characteristic waveform with various conditions. What happens to CVP and atrial fibrillation? Atrial fibrillation means there is no atrial contraction. The first is going to be absent A wave. There is not going to be any atrial contraction, so there is absence of A wave. Next is you can see the beat to beat changing morphology in the CVP. What was like before one beat, it will be different in the next beat, and you can see the prominent C and V wave. A wave will be absent, but C and V can be prominent, and you can see small amplitude pressure waves due to fibrillation or flutter. Now coming to waveform in ventricular tachycardia, NEET, or a complete heart block. Here the most characteristic is the cannon A wave. A large A wave is seen, and in tricuspid insufficiency there is a large holistic V wave, and there can be fusion of C and V wave, which is called as CV wave. And another important thing is the disappearance of the X descent. You cannot see the X descent in the CVP waveform in tricuspid insufficiency. Now coming to tricuspid valve stenosis, there is going to be large A waves and a slow Y descent. Here you can see a slow Y descent. That is stays with tricuspid valve stenosis. Now coming to pericardial constriction, RV infarction and restrictive cardiomyopathy. Here you have tall A wave and a tall V wave, and the Y descent is steep as well as the X descent is also steep. You have steep XY descent as well as a tall A and tall V wave. Coming to cardiac tamponade, here you have a tall A wave, tall V wave and a absent Y descent, absent or a diminished Y descent. Now coming to the summary, loss of A wave is seen in atrial fibrillation or flutter. Large A wave you can have in tricuspid stenosis, right ventricular hypertrophy, pulmonary stenosis or pulmonary hypertension. Cannon A wave happens in junctional rhythm, complete heart block or ventricular arrhythmias. Early or holocystic cannon V wave or a fusion of C and V wave happens in tricuspid regurgitation. Loss of X wave means your RV function is poor, RV systolic function is poor. Loss of Y descent is tamponade or tricuspid stenosis. Prominent A and V wave and steep X and Y descent, and a characteristic M sign seen with pericardial constriction. So to conclude, individual CVP waveform provide unique diagnostic clue about the circulation in various pathological conditions. The trend in CVP over time are useful in estimating fluid or blood loss and guiding replacement therapy. So one is with waveform and one is with number. CVP indirectly reflects left ventricular end diastolic pressure, which indirectly reflects the left ventricular end diastolic volume, provided the compliance of the ventricle is normal. But always remember, don't treat volume with pressure alone. Look for other parameters also and then treat volume with pressure. There is a significant range of normal values that a small change in CVP may reflect a significant alteration in circulating blood volume and right ventricular preload. You have to understand that. Thank you.